everyone. Hope you're all doing good. Thank you so much for joining for today's RRR YouTube series. As you are all aware, this is really to revise and repeat. I'm sure you are almost there in clearing these exams. However, this is a small effort from our side to make sure that you are already ready to give your exams in a perfect way. So today I'm going to deal with one of the tricky topics, but one of the most common topics which all the obstetricians need to be aware, that's the fetal monitoring. So I hope by the end of this, you would be happy with the CTG monitoring and how it is done, and probably few questions, a few CTG traces we would be actually doing as well together. Okay, let's kick start. Yes, this is a very important quote of the day. I think all the athletes or all the sports person, when they come up with failure, they do not say that, okay, I'm not going to get back and do this. So it is basically like where you start when you have started or where you have started doesn't matter, as long as you're trying to get up every single time you fall. So even while doing an EMQs or an SBAs, or while even when you're discussing with your friend or your mentor, you can go wrong. Doesn't matter. It's absolutely okay. Know your flaws, know where you're going wrong, and make sure that you accept that mistake and look for the solutions. This is the only way to make sure that you will be a winner in your difficult exams like the Part 2 MAS-UG. I would say it is difficult because stress always overwhelms all of us. So to make sure that you don't get stressed too much, I think you must be making sure. Deepti, am I audible? Because I think my screen was frozen. Am I audible, guys?
Yes, ma'am.
So to make sure that your stress is better, you need to practice and desensitize yourself. Okay. So today we are going to talk about the fetal monitoring. Let me go back to the basics. We are all aware of different methods of fetal monitoring. One is intermittent auscultation, which is commonly used for all the low-risk pregnancies, which the patients are also very comfortable. The second thing is fetal scalp electrode monitoring, which is exclusively done for the mothers where probably morbid obese women are where you are unable to do it through the abdomen. You do a fetal scalp electrode, which is actually an invasive one, as you can see here. Or the next one, non-invasive fetal monitoring, which is continuous, is a CTG. That is where our focus lies today. And there is a different version of CTG, which is a telemetry, where the woman can get up and move around, because with the CTG, what happens, the patient tends to be tied to the table. But with the telemetry, what happens, the patient can move around with a tape stick. You can see the midwife is actually having the machine in the hand so that she can still monitor. So if you ask which is the best method, actually the thing is, any method of fetal monitoring is suitable according to the patient's risk factors. Every low-risk pregnancies, without any other risk factors, no other concerns, you can always go for intermittent auscultation. However, high-risk factors, whether it is antenatal, intrapartum or postpartum, wherever there is a low-risk pregnancy who is developing a complication, or complicated pregnancies or the high-risk pregnancies, definitely you need an intermittent auscultations. CTGs, which is a continuous monitoring. So if you're doing an intermittent auscultation, what is the frequency and how would you go about? This is a very important thing which you need to know. As we all are aware, first stage is not as probably intensive as the second stage. In the first stage, immediately after a palpable contraction, okay, you felt the contraction, immediately after the contraction, at least 1 minute, you need to do an intermittent auscultation, and it is repeated every 15 minutes in case of first stage. But when you come to the second stage, it's usually every 5 minutes you do. And during the intermittent auscultation, if you have felt a deceleration, to tell a deceleration, that is which goes down, or an acceleration, because basically deceleration is dipping in the heartbeat, acceleration is an increase in the heartbeat. So if at all, whenever dip in heartbeat of 20 beats or increase in heartbeat of 20 beats, which is called acceleration. So if at all, while a midwife or a doctor is auscultating and there is a dip, of 20 beats per minute, you need to make sure, especially if the deceleration is heard very frequently, you need to be shifting to the woman for a continuous CTG monitoring. And if the trace is for like 20 minutes, you do this trace, and if that is normal, you can decide upon the case basis whether you need to continue or you can discontinue. I hope I'm clear so far. So coming back to the most important thing which I want to tell is, never ever consider your CTG as a sole tool to diagnose fetal hypoxia or to expedite the birth. Always consider CTG along with the holistic approach of your patient risk factors. This is a very, very important thing. Now, how long you have to reserve or preserve a CTG? This is a very common single best answer which people are always worried of. So basically, first and foremost important thing is documentation of the events along with the partogram and the CTG wherever you have got. Fetal blood sampling was done before, not anymore. So if at all you are doing anything, any procedure, you need to make sure it is documented. And how long the CTGs have to be kept? Ideally, CTG traces are kept for 25 years, if possible, wherever it is, and you will be storing them electronically. As you have seen, CTGs the print gets very, very light, so probably it is difficult. So that's the reason, if at all, if possible, you're going to keep the CTG electronically for 25 years. But where are you going to keep them forever? As much as possible, like indefinitely. Wherever there are concerns of baby developing CTs, like the fetal brain injury, it is a good idea to store indefinitely. As you all know, litigations can come at any point of time if the baby develops CP. That is the reason whenever there is a concern for possible, like you know that the CTG was bad when you took out the baby was floppy. So you know that the baby is going to develop HIE, or probably you are thinking of an adverse outcome, shoulder dystocia, whatever it is, you need to make sure that you will keep them indefinitely. This is a very, very important single best answer point, which people get confused. So know this very well. So I hope I'm good so far. Let's move on. The most important thing is how to read the CTG. Of course, I know you have exams nearby and you really do not have time to go through the CTGs very in depth. However, my point here is to talk to you about the basics, because sometimes they could give you the CTG traces. So you shouldn't be worried when you get the trace. So ideally, the ideal paper speed is 1 centimeter per minute. It is not our guys. It is 1 centimeter per minute. That is this one. The big box says it is 1 centimeter. And that is the horizontal line which is talking about. And the vertical line which you are seeing here is the heart rates. Okay. So whenever you are trying to assess an acceleration, deceleration, contraction, how long it is, you need to be doing that against the time given. So for example, here the deceleration, as I mentioned, remember you can call it deceleration when it is more than 20 beats per minute. Obviously, it is falling from 180 to 150. So obviously there is a deceleration and it is lasting for 90 seconds. How did I even say 90 seconds? This is 1 minute and this is another 30 seconds. So 90 seconds. So we have a deceleration for 90 seconds. Here you can see the prolonged bradycardia. Like this is a bradycardia which is longer. If this was carrying out like here, so prolonged bradycardia of more than 3 minutes. So this is a 1 minute, this is a 2 minute, and this is a 3 minutes. So that's how you'll be calculating the time. So whenever they say, okay, this is more than 3 minutes, more than 2 minutes, and the trace is more than 30 minutes. So you need to know how you're going to calculate. So whenever the trace is given in the exam, always look how long it is. Because when we go to the CTG classification, you'll understand there is a cutoff time of 30 minutes. So you need to know whether it is you're dealing with 20 minutes trace or a 30 minutes trace. Okay, so I hope there are no doubts which are posted in the live. So if it is any, please let me know. Okay, Dipti, are we good so far? Am I audible and the voice is clear, right? Okay. Fantastic. So now let's move to the next point. How you are going to assess your CTG. As you are all aware of, probably the famous mnemonic Dr. C. Bravado. The most important thing which you guys need to focus here is the first point is defining the risk. So if a midwife or if a doctor comes back to you and asks, tell me please interpret the CTG. The first question which you're going to ask is, please tell me the clinical scenario, so that you are analyzing your patient's CTG in view of the risk factors or in view of the situation. Why did I even tell you this? For example, somebody has been just started with epidural, and when you got the CTG trace, it has something like a pseudo-sinusoidal pattern. But if you don't know that she was started on epidural, there is a high possibility that you would interpret as probably pathological. So always define the risk. Next thing is contractions. I'm going to deal with all of this in a while. Contractions are very important. You cannot define your decelerations without the contractions. So always make sure, first thing you look in 10 minutes, how many contractions this patient has got, or the patient has got. Yes. The next is the baseline heart rate of the baby. So you should be very sure when you are assessing a CTG that this is the fetal heart rate you are monitoring, not the maternal heart rate. Okay. So if at all, if you are doubtful, you can always confirm with the ultrasound scanning. Especially this happens a lot when you put a internal fetal monitoring, that is fetal scalp electrode, or the woman is obese. So always make sure you are actually monitoring the baby. Next thing is the variability. That's the beat to beat variability of the baby's heart, which actually indirectly indicates the autonomic nervous system of the baby. That is sympathetic and parasympathetic system is intact and there is no problem. Next thing comes the acceleration. Acceleration is, as you know, as we run, the heartbeat increases. So if the baby is moving well and the heartbeat automatically increases, it's a good sign. But it doesn't mean if there are no acceleration, the baby is tired. No, accelerations is a good to see, but if you don't see, it's fine as long as other features are good. The decelerations is dip in the heartbeat. Acceleration is increasing, deceleration is dipping. Then you will divide each of them into zones, like a traffic light system, white, amber, and red, and then you come to an overall impression. So this was the panoramic view of the CTG. Now let's jump into each one of them. Okay, so contractions, as I was trying to mention, so this is the 10 minutes trace ideally. So from here to here, you see the 10 minutes. So you can see 2 contractions in 10 minutes. In the similar way, here, you can see almost 1 contraction in 10 minutes. Okay, so when you need to categorize the contractions, okay, for example, here, from here to here, you see how many contractions? 1, 2, and 3, and 4, and probably 5. So you see 5 contractions. So even for contractions, you need to be knowing whether you are dealing with which zone. Okay, so this comes to amber depending upon the number of contractions you've got. So whenever the contractions are more, either the number is more or you say hypertonus. Hypertonus is the strength of the contraction or the time of the contraction. Sometimes it can go more than 2 minutes, each contraction. So then you need to be really worried because the more pressure you are giving to the baby is going to be tired. So whenever you see things like this, always look into the scenario. Probably this patient is on oxytocin infusion. Probably she's on propess session. Probably she's on, probably something oxytocin drip which is running. So you first thing, stop the stimulus and see. So that you are trying to save the baby from the fetal distress. But if only contractions are there, you can eliminate by reducing the contractions. But if baby is already showing decelerations, that means to say it is not only tachysystole or hypertonus, along with that, baby is showing the signs of distress, then you immediately need to give a tocolytic. Hope I'm making sense here. Basically, when the contractions are increased, okay, if the contractions are increased only and the baby's heartbeat is fine, remove the stimulus. If the contractions are more and the baby is getting tired, please make sure to stop the stimulus and to give a tocolytic. Whenever you give a tocolytic, please make sure, if at all you're going to expedite the birth, there is a possibility that there is a risk of PPH because you have made a relax the uterus. This is a practical point which you need to know. Now, the fetal heart rate. I've seen people getting worried. How will I assess the fetal heart rate? Actually, you need to be seeing here. I don't know how much you are able to see. This is 100. This is, this is 100 here. So this is 100, 120, 140, 160, 180, 200. So whenever you calculate the fetal heart rate, whether you are doubtful whether this is this, whether it is this, or whether it is this, which you need to be looking. So that's the reason I have put this slide. If you see here, this at this point of time, it is 126 because that is what the cross line. So you don't go for the troughs. Accelerations are the decelerations. The midline which you take is the fetal heart rate. So the similar way, if you see, it is coming up to 130. So this is how you calculate your baby's heartbeat as you are seeing the CTG. You need to draw a horizontal line which cuts through most where the trace lies. And that is how you will be calculating the baby's heartbeat. Okay. So now when you come here, what is the fetal heart rate here? Okay, and what zone it comes. You see that basal fetal heart rate is 140 beats per minute. So as we are all aware, when it is 140, obviously it's a white zone. And when you see here what is the heart rate, it is red because if you could see, most of the trace is coming in here, which is around 180. So when it is 180, obviously it is a red feature. One red feature, you know, it is pathological. So when it is 110 to 160, there is a slight change which you need to focus from the previous one. So we divide all the important things to probably white, amber, and red, all the components like the heart rate, decelerations, variability. So that's how you need to remember. If it is 110 to 160, it is normal. When it is less than 100 or more than 160, it is red. And you could see this is amended in 2022. This is an important point because before there was a slight change. So let's forget that because this is important. But what is amber? Amber is because you have here 110 only. So between 100 to 109, it becomes amber. Or if at all, if there is an increase in 20 beats than what it was, you need to be very careful. I need to say, so when it started, it was 120 average, but now it is moving towards 150 for the last 20, 30 minutes. You need to be very careful. There's something wrong which is happening. Okay, so you need to be careful on that end. So I hope I'm clear so far. Let's move to the next one. So the amber and the red, you really need to know. So this would be able to give you a clear idea when you're assessing. Variability. What does variability means and where this helps? In cases of chronic hypoxia, basically whenever you are dealing with chronic hypoxia, you can see the beat to beat variability is quite low or compromised, which indicates that the baby is compromised from a longer time. It is not right now the baby is compromised. So in cases of IUG or in cases of baby who has been compromised from the beginning, you can see that. But what do I mean by variability? That is this up and down, what you see, okay, the peak and the troughs and the downs, this one, okay, the average amplitude with which I move, with which the baby's heartbeat moves, like 120, 125, 130, 125, 135, 130. So the baby is moving, the heartbeat is moving, okay, it is going on like this. If at all, if it is flat like this, that is not a good sign. Or there is something called variability, because if the graph, for example, graph should be like this, right? So this is how the graph should be, which says that there is a beat to beat variability. If I go like this, okay, which is a sinusoidal pattern, which is seen in fetal anemias, especially in parvovirus. So this is a really bad thing. That means to say baby's autonomic nervous system is compromised. Then, as I was trying to mention, the same one, you see something like this, where it is still, it looks like sinusoidal, but there is a beat-to-beat variability maintained. This is what is called pseudo-sinusoidal pattern, which is seen with epidural, pethidine. So when you see this, look for why the patient is, what the medication patient received, and with conservative measures, this settles down. So you need to know the difference between sinusoidal, pseudo-sinusoidal. Now, I hope you got the point of average amplitude in 1 minute segments. So this is what we are looking into. Okay. Now, again, these are divided, as I said, white, amber, and red. So white is the normal one, 5 to 25. That means to say the baby's heartbeat started at 120, but as it is moving, it is going up to 145. I'm okay. That means to say between 5 to 25, baby's heartbeat is variable, which is acceptable. But if it is going less than 5, okay, so the beat to beat variability is 120 to 122. It's very difficult to see. You can see in the trace. So where you see that variability is very low or very high, then you need to be careful. If you see here, whenever it is less than 5 beats per minute, always the time given is more, like half an hour to almost an hour. That is 30 to 50 minutes is given. Or whenever the beat to beat variability is more, you have a lesser time to move from amber to red. So remember this time frame in beat to beat variability. Amber is 30 to 50 minutes of less than 5 and more than 25 in 10 minutes. When you come to the red, obviously, once this zone is crossed, that more than 50 beats per minute or more than 25 beats in more than 10 minutes, then it goes to the red. So remember one thing, remember the amber point, obviously anything beyond that goes to the red. Okay, I hope I am clear so far. Okay, so here when you get this, what is this zone? Because all our CTG classifications, based on these sub-classifications, what is the zone? Let's look into what is the zone which comes to this. This is a reduced variability. You can see less than 5 beats per minute, obviously. But the trace, you remember, what was the time which I said? I said reduced variability has 30 to 50 beats per minute. And I have a trace of only 10 minutes here. That is the reason I'm going to amber. But here, more than 5 or less than 25 beats per minute for a longer time. Okay, which I have a trace which is longer, but this is a normal variability. 5 to 25 is normal, so that's why it is white. Here, if you could see more than 25, and the trace is more than 10 minutes. 10, 20, 24, and another 4 years. So 28 minutes. So obviously this will be red. Okay. So what I'm trying to tell you guys is here, one thing is to know how and what you're going to do. And the second thing is to understand the duration with which it is going. Identify lower variability, higher variability, then understand what zone it belongs to. Okay. I hope I am clear with this. Let me move on. This is what I was trying to tell you. Sorry, the image looks blurred, but I'm sure you can identify there is absolutely no beat-to-beat variability. So obviously, this is a sinusoidal pattern. So I mean to say this would be the red, correct? So whenever you see this, you have to really expedite the birth, either the cesarean section or the probably instrumental delivery, depending upon the place you are in. So make sure that this is taken care. Now, when we come to the decelerations, so now we have done with the heart rate contractions and heart rate we have done, variability we have done, acceleration doesn't need any special mention. The next thing people are worried is decelerations. Always remember, you cannot comment on the deceleration without the contractions. So you really need to know to decide whether it is early, late, or variable, the contractions which the patient is having. For example, this one, when you see, you can see that there is always a mirror image. For example, with my contraction starting, the heartbeat started dipping. And with the peak of the contraction, the nadir of the deceleration is matching. Once the contraction is over, my deceleration is over. So it is actually a mirror image of the contraction. And this mirror image is called early deceleration. Okay, whenever you see the exact mirror image that I started with the contraction and it ended with the contraction, exactly the nadir and the peak of the contraction coincides, it's in early deceleration. Obviously, early deceleration is something which is not very scary or not very like probably ominous sign for the baby. It is seen whenever there is head compression. What happens when the head gets compressed? When the baby's head gets compressed, there is a stimulation of the baroreceptors via vagus nerve. So you know that once the baroreceptors are stimulated, obviously the baby's heartbeat is going to dip. That is the reason early decelerations are quite commonly seen with head compression. Now, and this is, if it is seen, of course, you need to consider, but it is not very ominous sign for the baby. Now, when you come to the second one, where you are seeing the contraction has peaked. Okay, you can see here the contraction is happening, and this is where the peak of the contraction. And during the peak of the contraction, all this time, with the starting of the contraction, the baby's heartbeat was normal. Once the peak of the contraction happened, then the baby's heartbeat started dipping. Right? And once the contraction is over, okay, here the contraction is ended, that is when you can see the nadir of the deceleration coincides. That means the deceleration is later to the contraction. Okay, so with the peak of the contraction, actually the deceleration sets in. Once the contraction is over, the nadir of the deceleration happens. And obviously the contraction is over, but the baby takes time to recover and the deceleration is, you can see the recovery here. Okay. Obviously, whenever there's a deceleration, the gases gets accumulated and baby takes some time to push them off and start again. So this is a very typical late deceleration. In other words, decelerations which are later to the contraction, they come later than the contraction, they are called late deceleration. And this, when you see, you need to be very, very, very careful because these are mediated by the chemoreceptors. That is, all the lactic acid, that whatever the chemicals gets accumulated, and this one is indicating that the baby is not coping up well with the distress or with the stress of the labor. So when you see this, you need to make sure that the baby is assessed quickly and the decisions are taken. Obviously, late decelerations are the worst for the baby to have. I hope I am clear so far. Now moving on to the last sort of deceleration, which you can see here. Here it has started almost at the peak of the contraction, but it has ended before even the contraction is over because your contraction is getting over here. But if you see the deceleration, it has started within the contraction and it has ended within the contraction. Not even, it has waited till the contraction is over. That means to say, this is a variable to the contraction. It has no relation with the starting of the contraction, peak of the contraction, or end of the contraction. That means to say, it can start and end at any time in relation to the contraction. That is why it is called variable deceleration. And this is one of the commonest deceleration which you can see in the labor. And it can be seen with guard compression. Of course, I'll be dealing with variable decelerations in the next slide, where variable decelerations are common if there are no concerning characteristics. Okay, this is going with a contraction, but there is no relation according to the onset or the ending of the contraction is fine. But if there are concerning characteristics, then variable deceleration becomes most important for the obstetrician to review. So I hope I am clear with this because I've seen people literally struggling with this. I have one practical point to say. There could be CTG trace where you are seeing early deceleration, you could see late deceleration, or you could see probably even a variable deceleration without concerning characteristics. So you'll be wondering which one I need to look at. Ideally, whichever is repetitive or whichever is ominous, you need to look into that and classify. Whichever is the worst deceleration, look into that and classify. Because sometimes it could be seen when you get the trace, it looks like More than one type of deceleration is there. That's why I'm giving you this tip. Okay. Okay. So what is this zone? I have already named the contractions, deceleration. So it's easy for you. This is early because you could see most of them are the mirror image. Okay. And obviously this, looking at this, you can say this is a variable deceleration because it has no contract, no relation. It is starting and ending at some time. Obviously there are lots of things which are W and everything here. And here you could see the late deceleration. That means that it is starting here. You could say that it is, the deceleration is starting here. So this is a very typical of late deceleration. I understand the quality of the probably trace is not very good. Probably this was kept for a longer time. But there are lots of typical late deceleration. Now, tell me the zone, because I can see lots of you have joined me in the live. So tell me the zone. If you could actually name the zone, that would be fantastic. What is the zone? Whether this is white, amber, or red. So remember always this, whenever you see this, you should be extremely careful to look at the time. Okay, here you could see I have probably around 10, 20, and probably another 1, 2, 3, 4, 5, 6, 7, 8, 9. So 29 minutes of trace I've got here. Here I've got 10, 20, and probably 24 minutes of trace. I'll tell you why am I telling this. And here again, I have got 10, 20, and probably another 5. So 25 minutes of trace I've got. So is this important for you to look into if they give you to decide for the zone? This is for sure white because it's an early deceleration. When you come to this is amber and this is amber. So you must be wondering, this has a lot of concerning characteristics. Why we are not giving this red? Why we are not giving this red? That's purely because of the duration. It is less than 30 minutes. This is the reason you need to be extremely careful when you get the CTGs in your exam. So what do I mean is, you can see here, whenever there are decelerations, it is always like less than 30 minutes. Repetitive variable deceleration less than 30 minutes is amber. Repetitive late deceleration less than 30 minutes is still amber. Correct? So whenever you have anything more than 30 minutes, it goes to red. So that is the reason you need to make sure to decide the zone. I hope this is giving you value, because in the exam, they could give you 10 minutes trace, they could give you 30 minutes trace. So make sure to calculate the duration. Whenever you see any CTG, first thing always see centimeter per minute is there, and make sure that you are, how many minutes of trace you have got. Then you go for the contraction, then the basal heart rate, then the variability, then acceleration if it is seen, or the deceleration, because that would add value. So now I was talking about variable deceleration. So I was trying to tell you about with concerning characteristics. What is this concerning characteristics? So whenever the baby's heartbeat falls, okay, there should always be, the baby always tries to raise and then fall. And then again, when it comes to the normal level, it raises a bit and then comes back. This is what is called shouldering, okay? So it is like, you can remember somebody when they're crying, you will always give your shoulders, right? So it is something like that. You can remember this is the normal shouldering. But when it is overdone, you call that overshoot. Okay. So that means to say baby is literally struggling to come back to normal. So it is overshooting and then coming back. Okay. That's important. And if you don't see that increase and decrease, like whatever the shouldering which has to be there, okay? So if it is not there, you need to be really worried. And then if you could see here, when the baby's heartbeat is falling also, the autonomic nervous system is still intact. There is a beat to beat variability. But if you see here, it is becoming, if at all the same thing was smoother like this, you need to be worried. And if you could see here, there is a deceleration, that's fine. It is picking up immediately. That means the baby is trying to push off all the accumulated acids, lactic acid, everything, and it is trying to come back to normal. But if that is taking time, which is called late recovery, this is concerning characteristics. And here, if you see the baby heartbeat fell down, the baby trying to pick up. Again, it went down. Again, it is coming up. This is again not a good feature. So you need to see that these are the features, except this. The overshooting, loss of shouldering, smoothening at trough, late recovery, W, deceleration, or a biphasic deceleration are really, really not good. That means variable deceleration with concerning characteristics. So you need to be extremely careful about these. So that's why when you see, you also have a change in what you're looking into. That means to say, obviously with the deceleration thing, if at all, if you have no deceleration, you're happy. The baby is doing really good. But if you have something early deceleration, it's absolutely okay because baby is okay. It is just the baroreceptors, head compression, or the vagal nerve stimulation. And you are also okay with variable deceleration without any concerning characteristics because you know this as you thought it could be head compression, this could be card compression. But very important, no concerning characteristics. However, any concerning characteristics for more than 30 minutes, you need to be really worried. And repetitive variable deceleration, any concerning characteristic of less than 30 minutes. I'm coming to this. What is the difference between repetitive variable deceleration and repetitive late deceleration? If you see a variable deceleration with concerning characteristics of more than 30 minutes, that becomes amber. But repetitive decelerations with any concerning characteristics, even less than 30 minutes, you're worried, and late deceleration less than 30 minutes. I'll tell you what is repetitive. And red, if it is more than 30 minutes, are very specific. Acute bradycardia, that is, suddenly there is a prolonged bradycardia of more than 30 minutes, you are really worried. Okay. Now, let me tell you, what do you mean by repetitive late deceleration? So, I think that is coming in the next slide. Repetitive is in 10 minutes, for example, you can keep this as a trace, and you have 4 contractions, for example, or 5 contractions. Okay. And you are, probably I'll take a next slide so that would be easier. Just a minute, guys. Okay, let me take a next one. So what do I mean by repetitively deceleration? For example, you take this is the contraction from here to here. Let me take this is 10 minutes trace. 1, 2, 3, 4, and 5, for example. Okay. Let's consider this as contractions. Okay. And you have a variable deceleration or late deceleration. Anything you imagine, there is a deceleration of, let me take a different color which could be easily seen. Let me take a deceleration which is like this. Okay. Okay. So here, what I mean, this is repetitive. Why is more than 50% of contraction, that is 1, 2, 3, and 4. More than 50% of contraction for more than 20 minutes. Obviously, the same trace if you run back or run front. So if at all any contraction, which is more than 50% of contraction, it is seen for more than 20 minutes, you say that there is a repetitive deceleration. So whenever you see a repetitive variable deceleration with any concerning characteristic, even less than 30 minutes, you know that the baby is getting tired. A repetitive late deceleration less than 30 minutes, you would consider it as amber. Other than that, you see like probably out of 5 contraction, 1 contraction you're getting, you will be waiting for more than 30 minutes. I hope this is a very important principle which you guys need to be knowing. And I'm sure you will be able to probably come back to this and understand why we are giving amber or red. Repetitive is the word which is the key. Now, what sort of deceleration can you categorize? Okay, so if you see whether this is starting from the peak because it is not the mirror image, and this has started from here somewhere which is around the peak, and it has ended before this, and even you can see that here, and even you can see that here. Okay, so what sort of deceleration is this? So the main thing is this is a variable deceleration. Okay, you can see here overshooting. Okay. And obviously, this is 30 minutes trace. 10, 20, and if you calculate this 1, 2, 3, 4, 5, 6, 7, 8, 9, it is a 30 minutes trace. Okay. So this will become red and repetitive because with every contraction, there is a deceleration. Even though the contractions are less, with every other contraction, there is a deceleration. So definitely this is going to be red. I hope I'm making this clear because this is a variable deceleration because this has no relation with the contraction. Here you can see the overshooting. Of course, here and all it is maintaining the variability, but there is an overshooting which is seen. So obviously, if you continue this, definitely the similar one, or probably it will become biphasic or late recovery, I'm not sure. So all those things would be there. I hope this is clear. Now, so this is what I was trying to tell you. When you come to the divisions of this repetitive variable deceleration of less than 30 minutes, and as well, you know that when it is more than 30 minutes, when it is more than 30 minutes, it becomes red. This is what the definition of the repetitive deceleration. The same thing which I discussed before, I have put it here as well. Now I have identified all the features of my CTG. So what do I do with that? What do you guys do? The main thing which you guys do now is to categorize your CTG. Okay? That is the reason we did all this, right? So whether it is normal or whether it is probably suspicious or whether it is pathological. Correct? So if it is normal one, okay, that means to say no amber or the probably the red features. Everything looks okay for me. And if suspicious, any one feature is amber, pathological, either one red or two or more amber. So to make sure that you guys remember, I have made this table. Normal, all white, amber, suspicious, one feature of amber, pathological, two amber features or more, or one red feature. Correct? So this is what your CTG classification is. Now I have learned the CTG. What do I do with this? Making care decisions with this is very vital. So whenever you have a normal one, nothing to worry, continue, and you have to look into why did you start your CTG and then take it from there and continue the normal care. Suspicious. You have to make sure that you fully assess, look for underlying reasons and go for conservative measures. When there is suspicious with intrapartum risk factor, you can name it sepsis, meconium, anything like that. So you are worried. There are two factors which are already troubling you. In that case, urgent review by a senior midwife is important. And I'm going to talk about the fetal scalp, like fetal blood scalp sampling in the next slides. So you do a fetal scalp stimulation. If you see an acceleration, that means to say baby is good, along with conservative measures, of course. If that is not there, you need to think of expediting birth, depending upon the station and the situation she is in. Now, pathological one is very important to be reviewed by obstetrician and a midwife. Rule out an acute event, especially if there is a prolonged bradycardia or suddenly the normal CTG becomes pathological. You need to be careful. Again, you need to be doing the similar ones, conservative measure, fetal scalp electrode, and expedite the birth as quickly as possible. Okay. What is the thing about fetal blood scalp sampling? This was a very important procedure which could help that whether we could know how the baby is doing inside. The CTG was an external monitor. In fetal blood scalp sampling, we are going to take a drop of blood from the baby's scalp and see, okay, what's wrong. However, which used to give an indication of acid-base status of the baby. However, the NICE has mentioned that it is unable to make a recommendation about fetal blood scalp sampling because of the limited evidence. What do they mean by that? Because fetal blood scalp sampling needs 20 minutes to get the reports. So it was very clear from the beginning that in cases of acute events like abruption, cord prolapse, where you know a rupture, where you know baby or the mother is in trouble, you go ahead and you don't do FBS. But even if it is suspicious, even if it is pathological, we always used to think, okay, let's do the FBS and see the acid-base status. Based on the values, you would be deciding. But what they have seen is fetal blood sampling does not improve the outcomes, okay, as well as there was a delay in expediting birth. So there was an increased cases of HIE, that is hypoxic ischemic encephalopathy. And also, probably they have seen that in compared to CTG, in combination with fetal scalp stimulation, there was number of cesarean birth was also increased. So what did they say was, the committee, therefore, what they mentioned is, they were not balanced by the benefits versus the risk, which we usually do. So what they said is, by the end of 2024, the first study, which is focusing on the FPS and the neonatal outcomes, this is going to be finished. So after that, the committee is going to review whether fetal blood sampling could be a recommendation or not. So for your exam purpose, definitely there shouldn't be a gray zone where they mention fetal blood sampling is an option, because it is no more recommended by NICE, but at the same time, they want till the end of 2024 to give a decision. So what you need to be looking into is, if the baby is compromised, obviously look into the station and think of expediting the birth. Don't go for FPS. However, it's always a good idea to know the values of the FBS till that is completely removed. Just know the values, if at all, to understand which is borderline, which is abnormal, and the normal as well. Hope that's clear. Now we are doing a lot of fetal scalp stimulation because FBS is gone now. So obviously the next thing which you do is fetal scalp stimulation. Ideally, what they mention is with acceleration, that means when you stimulate the baby's head, if there is an acceleration seen in the CTG, it is a reassuring thing. However, if there is an absence of acceleration, it's a worrying sign. So fetal compromise could be present and expedition may be necessary. Obviously, this decision should be taken by consultant, and you need to look into the different features of what it is if the mother or the baby is compromised and take a decision accordingly. Hope I'm clear so far, guys. I can't see any comments in the live chat. So if you guys have anything, please go ahead and put in the live chat. I'm happy to answer them. Now, let's interpret a few of the CTGs. So who am I? If the moment you look into this, you are able to say what sort of CTG this is, because this element itself is so very prominent in the exam. If it is given, don't worry about Dr. C. Bravado. Once you have got this, go ahead, and especially this segment, go ahead and straight away put it as red. Because definitely there is a prolonged bradycardia. You can see this, how long? 1, 2, and 3, and 4, and 5, and 6, and 7, and 8. It's still going on. So obviously it's a red feature and pathological. Apart from that, of course, you have a variable deceleration, you have a late deceleration, you have a heart rate dip. So it's a very thing, and most important, take a systole. So if you see this, the next thing is, one thing is identifying a red, okay, but now what would I do? Obviously, the scenario is not given. You can see there is a lot of coupling of the contractions. So definitely there is a tachysystole. Is this my reason for baby being tired? So you need to look into the scenarios and make sure you remove that and start going ahead with the probably terbutaline, as I mentioned. So you could see stop oxytocin. Acute tocolysis, very, very important here, because there is a coupling of contractions. Turning on the side, ask to stop pushing if she is fully dilated, and if favorable, go ahead and go for instrumental delivery, because if she is fully dilated, obviously. So my point was, when I draw your attention to this, don't forget the lower column here, which would be helpful. Okay, I could see Neeraj's comment and Jaya's comment. Thank you, guys. Thank you so much. I'm really glad that it is, whatever I'm speaking is clear for you guys. Fantastic. So any doubts, please do put in the chat box so I'll be able to help. So the moment they give you the CTG, this could be something which has to do with the options of management in EMQ. So first, when you see this, obviously, you know it is red, but your job doesn't end there, because they will not be asking whether this is which zone or what category it belongs to. basically they would want to manage the patient. So look into the scenario. If at all, if it is something like a tachysystole and fully dilated, you need to reduce the contractions either the ways and then make sure that you deliver the patient as quickly as possible. Let's move to the next. Okay, so I think again here if you see, okay, so let's see here. Again, you are more looking into the bradycardia, but let's go with probably assessing a CTG. Okay, so the baseline here, somewhere around 140. Obviously, this is going too deep. Still here, it is 140, but after that, it has dipped. And then accelerations, if you ask me accelerations, they are there in between, but the most prominent is the deceleration. Okay, and the trace is definitely more than 30 minutes, and definitely there is reduced variability, and this is pathological. So again, you look into the scenario. Here there is a coupling of contraction again, guys. So you can see with the coupling only there is a tip. Okay, so see how many centimeters she is dilated. Is it because of probably you have increased the cento or you have inserted the propers? You can see lots of places wherever there is coupling, there is decreased one. So always look for the cause and treat the cause, guys. Okay. Saurish, I could see you are asking for Cat 1 and Cat 2. I have a couple of questions to do, so don't worry, we will decide for the same. So here in this case, okay, because you've asked this, so I'm talking about this. Again, here there is so much of a prolonged deceleration. Saurish, in this case, remember all the maternal complications like rupture, abruption, where there is hemodynamic instability, and prolonged fetal bradycardia are always category 1 CS. Card prolapse with abnormal CTG, or pathological CTG is Cat 1, but card prolapse with normal CTG is still Cat 2. So please remember, thank you, Saurish, for asking that doubt. It is very important to understand whenever you are thinking of Cat 1 cesarean section, it is generally under general anesthesia, because they have to do it very quick. So if at all, if you're thinking of this crash CS, it has to be like card prolapse with abnormal CTG, that's the fetal cause. Otherwise, all maternal hemodynamic instability like abruption, rupture, like anything, if you're maternal collapse, those things you take it as category 1 CS. Even apart from prolonged bradycardia, acute events, any other pathological and suspicious CTG would move to category 2. It is never Cat 1. I have a question. Don't worry. I'm going to actually send you these, will help you to decide for the category as well. Saurish, hope that is clear for you. I could see you had a doubt, so hope that is clear for you. Let's move on. Again, one more CTG, which looks fairly okay. So we are dealing here with a baseline heart rate of 168 beats per minute. Even though we think this was normal, so as we discussed, more than 160, it's always red. So make sure that this is taken care. Okay. And the next thing is accelerations. You can see hardly few accelerations here and there, which is still good. And do you have a decelerations? Yes, you have a deceleration, which are quite less, and probably it is more of an early deceleration. Okay. And variability is definitely normal here. So just because of one red, even though this normal looking CTG is so far normal looking CTG, because contraction seems to be fine, this became pathological CTG. Okay, so you need to be extremely careful when you look into the CTG. That is where your Dr. C bravado comes into the picture and decide for the further management. Okay, and I think this we have discussed. Okay, so this one, let's move to a scenario. Okay, because that is what you guys would want to know. Ruby, 34-year-old, primigravida at 38 weeks 6 days, induced with propes 3 years before. And the midwife is little worried about the CTG, so that's the reason she has come to this. Okay, so you can see here at the outset, you can see there's a lot of decelerations which are seen. But the catching point should be your contractions, because 1, 2, 3, and 4, and 5, and 6. Why did I start from here? This is the vertical column. Okay. So there are 1, 2, 3, 4, 5, 6 contractions in 10 minutes. So ideally, baby could be tired, but you're already troubling the baby with increased contractions. So what should you be doing? You should be removing the propes, which is a stimulant here. But will that stop your problem? No, because there are decelerations. Okay. So you need to make sure to give terbutaline subcutaneous so that you can release the contractions and make the baby feel better. So what do I mean here is, whenever you induce with prostaglandins, there is always a possibility that 1 to 5% will go hyperstimulation. What is the difference between hyperstimulation, take a systole, and probably, I would say, hyperstimulation, take a systole, and hypertonus? Whenever there is more than 5 contractions in 10 minutes, okay? So you can see 1, 2, 3, 4, 5, 6. So obviously, whenever there is more contractions, it is called tachycystole. Whenever the contraction lasts, for example, the contraction lasts something like this, okay? This is hypertonus, okay? That is called, when it is lasting for a longer time, it is called hypertonus. If you have a tachycystole or a hypertonus with a normal CTG, it is not called hyperstimulation. Whenever you have got a hyperstimulation, whenever you've got a tachycystole or a hypertonus with the decelerations, it is definitely called hyperstimulation. That is fetal distress with increased contraction, fetal distress with hypertonus is what called hyperstimulation. Then only removal of the stimulus won't work. You have to be dealing that by giving a tocolytic. If you guys like this point, send me a heart in the chat so that I know that you're all with me. Whatever I have discussed so far, if you're happy about it, send me a heart in the live, so that live chat, so I know that you guys are with me. So the next bit which I'm going to do is definitely solving an EMQ, because that's why you're all here. I'm sure that's why you are here. So whenever you get an EMQ, okay, my advice would be to read the lead-in statement. Obviously, there are various ways to solve EMQs, but my first and the best advice is to read the lead-in. This is called the lead-in statement, which you guys need to be reading to understand, okay, which way I'm moving in, like what I need to do by reading the scenarios, correct? So here, once you read the lead-in statement, the next thing which you need to read is a scenario. As you are reading the scenario, try analyzing the scenario, come to a conclusion, and then go for the options. Because the moment you go for reading the options, it could be A to T. So you're totally confused. And so many options with closure, one word here and there. So the best way is to read the lead-in statement, make sure that you understand what you need to be doing in the scenarios. Then you read the scenario and then you assess and then go back. Let's read this, okay, together. So in the lead-in statement, it says, above option shows various options of management. Following scenario shows the laboring woman with CTG. Choose the most appropriate management. This is what my thing is. So for the scenario, whatever I'm going to read, I'm going to make sure that I need to choose the appropriate management. Fine. So this CTG was recorded in a woman laboring spontaneously. As I'm reading, I'm going to mark the most important things. Spontaneously, so I know that it was not induced in a full term, so I'm not dealing with anybody with a preterm. Second pregnancy, multiparous. Her first baby had been born by a cesarean section. Okay, so I am dealing with a lady who is a previous cesarean section who started off labor on her own now, and that was cesarean was done for failed post-induction of labor. So 2 years back, it was induced and she went into cesarean section because of the failed induction. Now, she is 4 centimeters dilated and fetal scalp stimulation was done without much acceleration, probably. And the CTG is given. Now, what should I be doing? So I know the risk factors. First thing, remember, Dr. C. Bravado, the first thing is determining the risk. Previous CS in active labor. That's my risk factor. I have determined the risk. So now contractions. If you look into the contractions, it is probably 1, 2, 3. This you can say is contraction. Probably 3 contractions in 10 minutes, which looks okay. When I'm looking into the, so Dr. C is contractions looks okay. So when you look into the basal heart rate, it is coming when you draw the line here somewhere, because that is where the most of the line goes. It is somewhere around 180. Obviously, I know that I'm dealing already with a pathological CTG because 180 is more. Then accelerations, yes, there are a couple of accelerations which looks okay. And I know that I have to, 1 second. Yes. So accelerations are done. Then variability seems to be good here. So variability, I'm not concerned. Then comes the deceleration. Decelerations are something which I'm worried here. You could see here biphasic deceleration. This is definitely a variable deceleration. This is also variable deceleration. This is also variable deceleration. Here also there is a variable deceleration. There are repetitive variable deceleration. With every other contraction, there is deceleration. Obviously, irrespective of the trace, it is 10, 20, and 1, 2, 3, 4, 5, 6, 7, 8, 9, 29 minutes trace. But there is already, almost with every contraction, there is a repetitive variable deceleration. So I know that, of course, after this, you know that it has to be red because there is one feature which is red. So I know that I'm dealing with a pathological CTG, correct? So once I know it's a pathological CTG in a previous cesarean section woman, okay? So what my category should be? Whether I know that this is for cesarean section. Now I know she is for cesarean section because she's only 4 centimeters dilated and I've tried my conservative measures. Fetal scalp stimulation is done, but there is nothing happening. Now, which cesarean section is there? Now I need to look for the options which are cesarean section. So cesarean section is cesarean section. Let me change the color of the pen so it's easy for you guys to identify. So cesarean section. Start conservative measures could be there, but if scalp stimulation is there, I would have already done. Continued fetal monitoring doesn't help. Forceps delivery in room 4 centimeters not possible, and all these doesn't make sense. So FBS we are not doing anymore. So otherwise also in a previous CS when she has, so you are dealt with 2 things now, category 1 or category 2. Now, obviously you are in the habit of choosing category 1, but do you really think this needs category 1? I would completely agree if she had scar tenderness, if she had tachycardia, if she had a prolonged fetal bradycardia. Since any of that is not there, I would still choose category 2 cesarean section for her. Okay? Because category 2 CS doesn't mean that you are relaxed. There is definitely a compromise to mother and the baby, probably either or the baby, but at no point it has to be crash. So that is the reason I go for option C. Okay, so I want all of you to say me that it is clear because I've seen people struggling when they come for the category of the cesarean section. It is very, very vital and important. Unless you are dealing with a rupture uterus, you are not going to go ahead and decide for crash or category 1 cesarean section. Please type clear. People, whoever has joined me in the live chat, lots of gratitude. I could see lots of you have joined. Please type clear if I'm clear with this answer. Okay, so this is a very vital and important thing. Please make sure that it is clear. Thank you, Jaya, for that confirmation. It means a lot. Thank you. So I think these smaller things are the ones which can decide your 1 mark. Okay, I want all of you to type clear if I'm clear for that particular category of cesarean section. Okay, I'm waiting so that I would know you're all with me. Okay, so thank you for all those wonderful hearts and the likes. Thank you so much, guys. Thank you. Thank you, Nimala. Thank you, Jaya. Now let's do one more EMQ, which would be dealing with, thank you, Bhavana, which we would be dealing with a little complicated one where you might feel, oh my God, what would I do? Again, let's come back to basics. So you need to know that various women of different stages, CTG images attached. This can be used again. I'm more interested. I need to choose the appropriate management. So what would I do here? So I have a lady who is 27-year-old, nulliparous, weight looks a little more, normal GTT, no risk factors. Thank you, guys. Thank you so much. Saurisha, thank you. So I can see that she's post-dated, 41 plus 6, and she had presented with reduced fetal movements and BMI, okay, SROM clear, LOT, 250 palpable, 230 epidural was cited. Okay, she is now 8 centimeters with SROM, and this is the CTG given. Now, what should I be doing? So it looks like, except for the post-dated with the little class 2, class 1 obesity, because of course I don't want to calculate the BMI. So what I would be doing is to look into the partogram. Partogram looks, obviously, there is nothing which I can see here, so looks probably okay. And the next thing is CTG. I have absolutely no problem which I can see here. Okay, so how would I go about this? So what are the options which you guys will be choosing? Obviously, there are options of cesarean section, conservative measures, and probably none of the above, syntocinon, do nothing. So probably you will be, once you see do nothing, you feel like, okay, let me do nothing. There are one more thing, do nothing and continue the electronic fetal monitoring. So which one would be your choice? So which one is your choice? So can you all comment on which one is your choice, whether you are going for do nothing or do nothing and continue, or you would want to continue fetal monitoring, or you want to choose none of the above. What are your options in this? Which one is the one which you will be choosing? Yes, I'm waiting for your answers so that I know that what you will be answering in this. Because there are a lot of similar options and you guys tend to get confused. So which one you think will be suitable, whether it is E, whether it is K, whether it is M, whether it is N. So if you have a different answer, I would be happy to know as well. So I'm trying to make sure that you guys understand this. So which is the one which you will be choosing here? Okay, I could see lots of comments. Jaya and Bhavna saying it is M. Okay, do nothing and continue. Okay, if you guys tell me why do you want to continue the electronic fetal monitoring? Because there is no problem as such. So why do you want to continue? Why do you want to continue? I agree if you do nothing and continue electronic fetal monitoring, but why? Others, I need answers from you as well. Perfect. There is continue fetal monitoring is also there. Guys, the best option would be do nothing and continue fetal monitoring for 2 reasons. Okay, the one thing is she's on an epidural analgesia and her weight is 109. Okay, so obviously when the woman is obese, it might not be an appropriate thing to continue intermittent auscultation. So that is the reason. And with epidural, you would be going ahead with continue electronic fetal monitoring. You could choose continue fetal monitoring. What is wrong? Correct. But right now, do you want to do anything? Because a midwife or somebody has come to you, what should I do? You should say, don't worry, don't do anything. Go ahead and go on. Continue the fetal monitoring. That is the reason. I could see one of you, I think Srija has put that continue fetal monitoring. That is correct. But right now, what is the thing which you need to choose? Right now, don't do anything, but please continue the electronic fetal monitoring. I hope I am making sense. So congratulations for people who ever chose M, and also congratulations to people who didn't choose the correct answer, because this is how you learn. So read the options carefully. Okay, that's very important. Now let's do the second one. Again, I think here, the CTG, again, I need to choose the appropriate management options. Okay, where they are talking about probably CTG and a laboring woman. Let's go to the options what they have. Okay, so if you guys are happy with the explanation, you can just, the previous one, you can just leave the heart, say clear. So I know that you are happy and I'm okay to move to the next question. Okay. So here, when I read this question, okay, so whenever I read this question, it's always like, this CTG was recorded in a woman laboring spontaneously at a full term in her second pregnancy. So I'm dealing with a woman who is laboring spontaneously at a full term in her second pregnancy. Just a minute, guys. Okay, so I'm dealing with a woman who is laboring spontaneously. Okay, full term. First be born by, I think this one we did, I think 2 years earlier because of fail. I think, sorry, this was the same thing which we did before. So this, you know, it is a category A2 CS. So let me move to that next one. Okay, sorry. So this one, again, here I have not given any answer. It's a flashpoint. Okay. So let's see, how would you be able to do this without options? Okay. Deepthi, are you there? Am I clear so far? Anusha? Is everything clear so far, dear?
Yes, ma'am.
Okay, fine. Thank you. So let's see this, because I was just trying to coordinate with the live as well. Just a minute. So let me open that screen as well, because if somebody has a doubt. Okay, let's read this question. So if somebody has this EMQ flashpoints, you need to tell me what is the thing which you guys would want to answer us. Let's read the question together. Mrs. X, okay, laboring spontaneously, okay, at full term and first pregnancy, okay. Lipo was thick meconium stain, but there were no other risk factors identified, and at the time this recording was obtained, she was 5 centimeters dilated. Her CTG is as follows, started conservative measures. So I am dealing with a woman, primi gravida, full-term pregnancy with a thick meconium, and also she's in active labor. That is the gist which I can get into. Now, when I'll just zoom this for you guys to look into. Okay, so when you see this, what is the CTG is all about? Okay, so you have to, I'll let you take a minute and then probably answer me, what is the appropriate option for this woman? What is the next appropriate option for this woman? So I'm waiting for you guys to answer in the chat box. What is the most appropriate next step for her? Because you know the risk already, right? That you know that she's a primi gravida, a term, thick meconium, active labor. So what would you want to do? Okay, category 2 CS. Okay, she's 5 centimeters dilated. Okay, so category 2 CS. Okay, Neeraja says category 2 CS. Anybody else? Anybody else? Yes, guys. First thing, assess the CTG. Okay, my suggestion would be to assess the CTG. What is that which you're worried, and why do you want to? What is your next step? Yes, guys, I'm waiting. I'm waiting for you to answer. Please go ahead and answer. Thank you, Neeraja, for the quick response. Yes. Okay. So now let's look into the CTG. Okay. If you look into the CTG, the heart rate is somewhere, initially it was around 180. Now it is coming somewhere around 170. Okay. You can see this is the 160, 170 range. Okay. So what is the thing which you, next, rest of the things are fine. You can see the contractions are not much. There are no much of a deceleration. So what is the next thing which you guys do, guys? Think, be quick. What is the thing which you do? Okay. The most important thing which you need to do here, obviously, you can do fetal scalp stimulation. You can do, remember conservative measures are started, but look for causes of tachycardia. That is a very, very basic thing. Always, I could see Bhavana's message that you want to continue the trace. Fantastic. But there is no point continuing somebody who has a tachycardia without looking for the cause. Expediting at this point in time, it could be possible, but I want to know, probably mother has a fever, right? And expediting delivery comes only after knowing the other risk factors. I do understand, because now it becomes amber with meconium, so you are worried what to do. But before you jump to anything, please look for causes of tachycardia. I hope this helps. Okay, so look for, it could be anything, whether you could even go for category 2, category 1 CS depending upon the risk factors. But my thing was, what is the next appropriate when you see, because nothing else is worrying, you are worried for the tachycardia. Hope that helps. Now, let's move on to the other random scenario where I want you guys to focus on, because there could be lengthier scenarios like this, right? So I want you guys to focus on this, so that you know whenever you get the scenarios like this, you will never go wrong. So let's start reading. I think, Bhavna, I zoomed also and showed, I explained also 180 to 160. But however, you need to know that, because the scenarios could be very different and the trace need not be perfect, but always look for what is the most important element which you can see. Now let's read this scenario, okay? A 23-year-old, okay, I hope you're all with me. A 23-year-old, okay, has undergone an induction labor at 40 weeks, 6 days in her first pregnancy, okay? So antenatal care was complicated with an admission to the hospital with small painful antepartum hemorrhage at 34. Symptoms settled spontaneously and all investigations and monitoring were normal. Her blood group is AB positive. So it's fine. I have nothing to worry here. Vaginal prostaglandin gel established labor within 3 hours. So she was in induced labor. Progress such that 6 hours later, cervix was 8 centimeters dilated. Fantastic. So far, she's post-dated in her first pregnancy. Okay, so first pregnancy, she's post-dated, and she was antenatal care. There was an antepartum hemorrhage. Now she has been induced and she's 8 centimeters dilated. And other thing was, there is a meconium stain like her. She's on epidural anesthesia as well. 3 hours later, fetal head is 1/5 palpable and the cervix is 9 centimeters dilated. Position was LOT with minimal capital molding. Okay, so till so far, there are a couple of things which has developed. She was on epidural was started, meconium stain. Now she's 9 centimeters dilated. Now what is happening? So the CTG had a baseline of 165 beats per minute with no baseline variability. So absolutely, it is less than 5 beats probably, but I don't know how long this has been happening. No accelerations or decelerations, and a small amount of post-examination vaginal bleeding was noted. The fetal heart rate then unexpectedly dropped to 85 beats per minute and does not recover. Okay, now I am dealing with a patient who is primary post-dated induced with an antepartum hemorrhage history, but right now there is a small amount of bleeding as well as there is a fetal heart rate drop, and also there was a reduced variability. So what you guys will be doing for this? I shall wait for options. Go ahead and tell me what is the next best management for her. So tell me the next best management for her. Yes, guys. So I'm just waiting so that You will all be able to come back with an answer. Next best management for her. According to you, what is the next best management for her? Okay, I'm giving you a minute's time so that you would be able to do. Okay. Category 1 cesarean section, as Bhavana is trying to tell me, Nimala says expedite the delivery by forceps, LSCS category 1. Nimala, the only point is she's 9 centimeters dilated so far, so you don't know what is happening, right? LSCS, okay, in the by forceps in the OTR cesarean section, LSCS category 1. So guys, I just want to bring this to your own thing. Okay, category 1 CS, you will be doing. So generally when you get substitution, she was 9 centimeters dilated. The first and foremost thing what you guys do is, you go ahead and shift her to the OT assess. Because she was 9 centimeters dilated. I agree that you don't know the dilatation, you don't know the station, you don't know a lot of things. But you will always do this in clinical practice. Shift her to the theater and examine her and see if at all she can be reassessed. Okay? So this is the most important thing which you guys will not forget. If you have an option, transferring to the theater for a reassessment with a view to an instrument delivery. I'm not telling that I would deliver her by an instrument, but it is very, very important to look into this option if you have. And I had not given the whole EMQ. There are options of that. Of course, you can't say with guarantee that you're going to apply the forceps, as Manisha was trying to tell. Obviously, she was actually coming to that direction and Jaya has answered correctly. So you will never know who will be able to deliver unless you know the whole scenario. So hopefully you understand where in actually EMQs you guys go bad. Okay, so just think, look into the options and then answer. Okay, guys. So I think with this, I have actually given you guys a bit of a clarity on the CTGs and the type of CTGs what you can get and also how to apply. So remember, yesterday is a history, tomorrow is a mystery, and today is a gift. And that's what you've called that is why we call it present. And you all have an ability to clear this exam in one go. So I would need a heart from you that probably show me your heart and send me the hearts to show that you will be fantastic in the exam. What I mean is, why I'm asking you to send that heart is to show that you will be able to analyze and apply your concepts. If that is done, nobody can beat you in this exam. So all the very best. Make sure that you guys read the question carefully, analyze the question carefully. You already have the knowledge, especially in labor and delivery. Whenever you have got a scenario, put the patient in front of you and make sure to analyze in that way. Yes, Nimala, I got your point, and that's why I mentioned you as well. You're all doing fantastic. I could see lots of you are applying the concept. Make sure to apply this concept and may success be yours. Hope this RRR series has helped you guys, and I have focused more on the CTGs because I could see lots of you were worried. All the very best and may success be yours. Thank you for watching me live, and make sure to subscribe to get the next ones and don't miss the session. Okay? All the best and stay blessed, guys. Thank you and God bless all of you. Thank you so much for your time and energy. Thank you, guys. Thank you and take care and bye-bye.
Recording stop.